Dr. Manish was also Manish was also in that Delhi conference.
Yeah,
Were
yeah.
you online or you were there personally, sir?
No. I'm in personally there. I'm in the hotel room right now, going for the faculty dinner. So just
You
I
are
thought
in Delhi. So
Delhi.
you have
Yeah,
not
yes.
returned to Lucknow.
No. I'm in Delhi right now.
Okay.
Yeah.
So today is a busy day for Indian stem cell study group.
Yeah, correct.
Yeah.
A wonderful
Yeah.
day. And that way, from the southern part of the country, northern part of the country, everybody is doing their efforts under your guidance, sir.
So actually, this will be a small introduction to Dr. Charmila.
Yeah.
So, Dr. Charmila, so we have a group called Indian Stem Cell Study Group, which was registered by Dr. Manish Khanna.
Okay.
So we belong to all multiple specialties. So both of us are orthopedicians, but Dr. Manish was also an orthopedician. And so we have all other specialists also, like ophthalmologists, gynecologists, andrologists, and other specialists. So this we have been meeting every year, twice, thrice, and then decided to form this Indian Stem Cell Study Group. And then with this, we have had multiple interactions with people who are into this field of stem cell therapy. So this is a growing body. Now what we have done is we have made separate chapters. Like this is a regenerative medicine. This is a gynec chapter. So where we want to involve people who are interested in this regenerative medicine. So similarly, we have an orthopedic panel, we have the plastic surgery, we have ophthalmology. So, and webinar is being conducted under the Indian Stem Cell Study Group with each of these subspecialties. So this PRP stem cells and all are being used by dermatologists, it is used by gynecologists, used by orthopedic surgeons. So multiple specialists have already started using this. So now we are trying to put together all our experiences so that actually the way stem cells work is common for all the tissues. So we are able to regenerate every tissue. So we are now assembling all these data, all our experience, so that at some point of time we can give guidelines. We can start giving guidelines, what to use, when to use. And then we are also simultaneously getting involved in the regulatory aspects also. So what are the regulatory requirements? So all those things also we are assembling all the details. So we will be telling about that also. So in this meeting, so we will be just outlining some of these also.
Okay.
Yeah. Thank you so much.
We are ready, sir. Ready to go.
Yeah. Everybody is busy. Everybody is. So I think we will start, and then we will record this, and then when you post this in YouTube, then people can have a leisurely. They can see the contents.
Correct. Perfect. So Natesh, you just tell, then we can start it.
Yeah. So I'll just make some official announcement. Let me share the screen here from here. So good evening, everyone. So we are happy to announce our expert opinion symposium, and we are happy to have regenerative gynecology subspecialty of Indian Stem Cell Study Group. And today we're going to talk on the prognostication of fertility treatments with regenerative therapies. And I want to introduce the founder president and the current chairperson of Indian Stem Cell Study Group, Professor Dr. Manish Khanna sir is here. Sir, please inaugurate the session, sir.
Yeah. Good evening, namaskaram everyone. So it's very nice to be a part for Indian Stem Cell Study Group, as from the northern part and the southern part we are today doing a live workshop as a symposium also. So lots of congratulations to Dr. Nitesh, Dr. Ravi sir for organizing this Shaft Expert Opinion Symposium, a webinar which is very important for the regenerative gynecology. Highly thankful to faculty member Dr. Naina Patel, who is already a chairperson of the regenerative gynecology section of Indian Stem Cell Study Group, and Dr. Charmila for joining us. And as we all know that BMAC is a very important component and it is for multiple users, it can be done. Today we had a workshop here in Delhi Orthopedic Conference for the orthobiologics, and we know how the rich BMAC is. Hats off to Dr. Naina Patel for publishing a lot of data on the BMAC, especially for the thin endometrium. And I think across the globe, especially in India, with the increasing population and the stress, and there are so many factors for which the thin endometrium is responsible for creating a lot of issues, for which this is a wonderful webinar. I hope it should go very well. So lots of congratulations once again, and we're going to start the webinar soon. Thank you so much. Yeah, over to Dr. Nitesh. Dr. Nitesh, are you here?
You have to unmute yourself, Dr. Nitesh.
Thanks for the brief introduction, sir. So I just want to introduce Dr. Ravi sir, who's the Vice President of Indian Stem Cell Study Group. Ravi sir has a very unique experience of working with multiple fields of experts in case of regenerative therapies, starting from dental surgeon, he himself being orthopedic surgeon, and his wife, late Dr. Vidya Ravi ma'am, she's being a gynecologist, and with the andrologist, Dr. Vasan sir, and with a neurologist, with rheumatologist, with immunologist, with nephrologist. I keep on piling the names. Even he has worked with pediatricians who has given intrafetal stem cell therapy to reverse a genetic disease. So Ravi sir is very unique in this kind of expertise. So before going to him, I want to give a prelude of why I'm telling this much amount of with Ravi sir, because Dr. Vidya madam, I'm just going to share the slide to show about her. So hope the slide is visible, right? Yeah. So Dr. Vidya madam, she has worked extensively on thin endometrium and poor ovarian reserve, and her research was very crucial in developing the initial evidences. And later on, when Ravi sir met a lot of experts, and he was able to share their own personal experiences. And now today we have two speakers, and before that, I would like to have Dr. Ravi sir say his decade of experience in field of regenerative gynecology, very specifically. Please, sir.
Thank you, Dr. Nitesh. So this is a wonderful opportunity for everybody to learn from the panelist, Dr. Naina Patel, as well as the moderator, Dr. Charmila. I just want to make two statements. One is that all of us know infertility is rising, and due to multiple reasons. So because of the altered food habits, sleep pattern, the lifestyle changes, and other things. The other important statement is that the failures of infertility treatment is also rising. So what is the success rate and what is the failure rate? And if the failure is happening, it is due to or in spite of the drugs, the hormones, the nutritional supplements, lifestyle changes, which the doctors usually prescribe for the patients. So in spite of following all these routine protocols, there is a failure rate. So how to improve this success rate of infertility treatment apart from using these drugs and other things? For the treatments like IUI or IVF, which has so many challenges. So for this, we need to change our approach from the use of drugs and hormones to regenerative therapy. Already a lot of gynecologists are using PRP. So PRP is now very popular among dermatologists, among orthopedicians, and among gynecologists. It is very popular because many gynecologists have started using it for both endometrial as well as for ovarian regeneration. But there are only few people who have used stem cells, which are more powerful than PRP for regenerative approaches. Stem cells. And if you search our Indian FDA or SEDESCO website, you can find that hardly there are only 2 centers which are approved by the SEDESCO for their GMP facility to use stem cells for infertility. So this particular approval has been approved, has been obtained by Dr. Naina Patel in her facility at Akanksha Center in Anand, Gujarat. So I think it is our privilege that we have got Dr. Naina Patel, madam, to talk about the role of regenerative medicine in infertility, this being the first such talk for this subspecialty. And we are very honored to have Dr. Charmila, who is going to moderate the session. So she is a leading gynecologist in Trichy, and she has been taking very active part in the Gynec Association. And I think it's time we hand over to Dr. Charmila to start the session by moderating. Thank you.
So thank you, sir. Before going on to that, I want to introduce the speaker and the moderator for today's topic. And so today's topic will be on a prognostication of fertility treatment with regenerative therapies, because many times what we find is people they talk much about regenerative therapies, the main thing being PRP or bone marrow mononuclear cell therapy or next of mesenchymal stem cell therapy. The ultimate endpoint achieving would not be possible, but what they will understand, they have to prognosticate how the treatment is, how their treatment has been evolving, and how they can manipulate the main core, the medical management. So I'm happy to introduce Dr. Naina Patel madam and Dr. Charmila madam as a moderator. So Dr. Naina Patel is a medical director of Akanksha Hospital and Research Institute, which is in Anand, Gujarat. And for Ziva IVF, she is considered as a pioneer in the field of IVF and surrogacy in India. And I have visited a center personally, one of the top class centers, and for surrogacy as well as for regenerative medicine. And I want to share a very specific thing here before going into that. And she's being the president of State Obstetric and Gynecology of Gujarat, the founder president of Gujarat Chapter of ISAR, and she has been authored various books, and she's been honored in various talks, even in the Oprah Winfrey show, and a reviewer of the various journals, published first case of thin endometrium, and published the first pilot study of autologous bone marrow derived stem therapy for thin endometrium. These two things, where myself and Dr. Ravi was there for the first thing, and she was there, and they extracted the bone marrow cells from the patient's iliac crest, and with the help of the radio guided imaging, they are able to go into the uterine arteries. I believe Madam will be telling about that, and we are so honored. And I welcome Madam for this session, and thanks for sharing your valuable time with us. And Dr. Charmila Ayava Madam from my home city, from Trichy, Tamil Nadu. She is a Vice President-elect of FOXY 2024, and she is a research chairperson of the Clinical Research Committee for the FOXY, and he was ICOG governing council member, national coordinator for UNICEF FOXY, and she was the serious governor of ICOG General Club, and WHO Southeast Asia region, MDSI India member, past secretary of TRIOX, that is TCOG Society, the president of Menstrual Hygiene Management Consortium, the secretary of Justice India Association, and the current secretary of Academic Wing of Assisted Reproduction in Trichy, ART. So once again, so thank you, Charmila Madam, for sparing your a valuable time amidst your busy schedule. And I would like you to take the stage and welcome the speaker. Thank you, Madam.
Thank you so much, Dr. Natesh, for that very, very kind introduction. And it's always an honor to be in a program where Dr. Naina Madam is giving a talk, and we always look up to her. She's been a pioneer in. She's not considered. She is the pioneer in surrogacy and IVF in the country, and it's always in the front of many innovations and introductions in IVF. And it's an honor to be there, Madam. And I'm very eager to learn from you, like how the new trend is going on, because as Dr. Ravi said, we have got lots of unexplained infertility and we are shooting in the dark. We don't even know what we are doing. We just keep on repeating the hormones, and it's something we would like to learn from you. And to your talk, ma'am, we're eagerly waiting for your talk. Thank you so much for the opportunity.
Thank you, Dr. Charmila. I'll share the screen now, please. So I'll start my presentation. 1 minute, there's some issues. Sorry, I got disconnected. Thank you, Dr. Manish, Dr. Charmila, for that wonderful introduction. You are a very active Foxian, and congratulations on being the Vice President. And thank you, Dr. Ravi and Dr. Natesh. So I will, without wasting time, which I already did because of the technical hitch, I'll start my presentation today. A very important topic on prognostication of fertility treatment with regenerative therapies. First of all, I would like to pay a tribute to the pioneering work done by late Dr. Shankar Narayan, and of course, the help that Dr. Ravi has provided us to start this state-of-the-art regenerative medicine for infertility. We know that there are two separate roads, but in the end, I will show how they are hand in glove with one another. With 15% of couples suffering from infertility worldwide, and with very limited options now that we have IVF, ICSI, yes, but patients are not willing to use the donor eggs, donor sperms, or a surrogate. They want to use their own eggs, own sperms, and their own uterus to conceive and have a baby. Or they are having repeated fertilization failure. And now also PCOS and endometriosis. So I'll start with 4 to 5 case scenarios. This girl is 28 years old with 0.30 AMH and 1 miscarriage. She was advised donor egg. This patient, again 1.56 AMH from the UK, had 2 failed IVF failures in UK, 2 PN arrest, and approached to me because somebody had suggested donor eggs and she didn't want to go. A young girl working in a radio therapy department went for amenorrhea with with almost 0 AMH. And then this lady, 0.04 AMH, you can see that the endocrinologist had referred for a donor egg cycle to us, and her AMH was 0.04, but she never wanted donor egg. She wanted her own eggs. And finally, this lady from the US, Canada, had 1 missed abortion. AMH, which was 2.8, suddenly drops to 0.25 in 1 year. She had 3 failed IUIs and she wanted to have a baby of her own egg, not a donor egg. And another case scenario where the AMH was 0.22 only with irregular cycles. The pathogenesis was unknown. She never wanted donor eggs. And this lady, she had refractory tuberculosis. The endometrium was refractory due to tuberculosis. Amenorrheic, 3 IVF cycle fails, advised surrogacy, and approached me, but she wanted to conceive on her own and not have the help of a surrogate. So the science was limited. They were all advised donor eggs or surrogacy. But is there a role of regenerative medicine that can help them conceive with their own eggs and use their own uterus to have a baby? So regeneration is by a is a process in humans where a lost specialized tissue is replaced by proliferation of undamaged specialized cells, platelet-rich plasma, and the stem cells. I will not go into the details of the procedure, but we know that platelet-rich plasma autologous can deliver supraphysiologic concentrations of growth factors, which will signal the molecules locally at the site of tissue injury and help in healing efforts because it secretes a list of growth factors. But we have to be very clear, either you use the ACDA solution or there are vacuum blood collection tubes also available and blood collections bags pre-filled. But there is a very important aspect to it that it has to be done very rightly, activated very rightly, and used within a stipulated time of the activation. Autologous platelet-rich plasma efficacy in the field of regenerative medicine is a very good paper which shows the product and the quality control. We need to do all this before we say that we are doing a PRP therapy, because it can't be prepared at one place, it can't be used at the other place, and the usage should show and document that the platelets have gone up, the granules are breaking. That all should be done very meticulously to get the best results. Otherwise, it will give a bad name to this beautiful therapy. And now we know one more thing, that the mesenchymal stem cells, when they are put in the along with the platelet-rich plasma, there is proliferation and differentiation more of the mesenchymal stem cells. So as a protocol, now we use platelet-rich plasma for suspending the mesenchymal stem cells. This is the procedure where the anticoagulant is 2 ml, 18. Now we prefer to take almost 28 ml blood in 3 different test tubes. We don't centrifuge it 2200, take the supernatant out, again centrifuge it for 10 minutes. And then that the buffer is there, the supernatant fluid is kept. If it's ovarian rejuvenation, as a rule 2 to 2 ml on both the ovaries, we dilute it with that. Or if the ovary volume is good, we can go up to 3, and if the volume is less, even 1.5. For just intrauterine PRP, about 0.6 ml. For hysteroscopic subendometrial PRP, about 3 ml. And for uterine artery, we use mainly stem cells. Stem cells are also revolutionizing healthcare, and these stem cells have a promise for infertility because it has multidirectional differentiation, angiogenesis, immune regulation, and paracrine stimulation. We have had number of branches where all this regenerative medicine was used, but if you see this diagram, reproductive medicine was missing, and that is what we have started now. Because there is a mechanism, the stem cells will migrate to the injured reproductive tissue caused by chemokines and then differentiate and integrate into somatic cells with non-tumorigenic properties. So even in the granulosa, cells participate in follicle development, regulate the ovarian physiology, including ovulation and luteal regression, and they can ameliorate the damaged microenvironment by producing paracrine factors, and the stem cell transplantations can restore the endocrine function by secretory anti-inflammatory factors or increasing the Treg population, leading to immune suppression. We are mainly going to talk about the multipotent, that is the adult stem cells, and we get it from the bone marrow, though you can get it from adipose tissue, umbilical cord, dental pulp, menstrual blood, and human milk. This is the typical stem cell aspiration procedure. We don't want to give pain to our patients, so we take it under short general anesthesia, and it is with a special needle which is available, and it is from the anterior iliac crest, sometimes posterior iliac crest, and we would want 80 ml, but 50 ml, 40 ml, 60 ml is also good enough, and this is how it is aspirated. And we use the SEPEX bone marrow processing unit to separate the mesenchymal stem cells. If we look at the role of regenerative medicine in infertility, female, male, both it has role, from the ovary, endometrium to the testes. Ovarian rejuvenation, previously we thought for diminished ovarian reserve, the regenerative medicine is best. But even for ovarian insufficiency, not primary, but premature ovarian insufficiency, when there is fertilization failure, recurrent miscarriages, or low success rate of infertility treatment, PCO, endometriosis, and even reversal of menopause. A procedure of creating new ova in the damaged or aged oogonates. We even know at menopause, the females have about 1,000 dormant oogonia in their cortex of the ovaries. So competent oocytes could be retrieved after activation of those primordial follicles in patients with DOR or POF. And ovarian rejuvenation not only restores the fertility, but it can also alleviate some of the side effects associated with low estrogen, POF, and menopause. So this is typically the cortex and where the oogonia are lying, and that is what being used. Now, there are several papers which have shown that the transplantation of the PRP or bone marrow-derived stem cells can improve the ovarian function. And the mechanism mainly is that there is an immunomodulatory effect with reducing TNF-alpha, anti-inflammatory cyclones are there. There is anti-fibrotic effect, and there is regulation of angiogenesis, which is also very important. But most importantly, the folliculogenesis and regulation of the granulosa cell survival and reduction of apoptosis and atresia, regulation of pro-apoptotic proteins, and promotion of cell proliferation. And we know granulosa cell is very important for a good competent oocyte. So these are the various studies. But when we do ovarian rejuvenation, we should always document there is a normal karyotype. It's not a Turner or Turner mosaic. Then the patient is between 18 to 40, we go up to 45. And recently we have got a result in a 46-year-old lady also. Secondary ovarian failure, we should exclude. At autoimmune disease, we have started with a proper counseling, but it's not a long-lasting effect. Like this could be effective up to 18 months. Also, we have seen result in 2 years. But in autoimmune, the result will not be long-lasting. And we have to rule out any malignancy or any hemopoietic disorder. We can do it PRP and bone marrow derived stem cells. We can instill it transvaginally under ultrasound guidance in both the ovaries. Laparoscopy, though we prefer if it is bone marrow stem cells, definitely, because there is a direct access, a direct view, and you can go right into the cortex without any spillage of the PRP or the stem cells. And you can also go to the hilum of the ovary where there are vessels going to the ovary, and these are important for neoangiogenesis and ovarian tissue activation. So once the stem cells are prepared, you activate it when the anesthetist is ready for the TDS installation, and within 15 minutes of activation, when the granules of the PRP are breaking, is the time that you instill it in both the ovaries. It is very much like an egg retrieval procedure. Here we are putting inside. So our person is properly trained to just inject it very slowly. We go, we identify the ovaries. Previously, we have to find out that the ovaries are not adherent, easily accessible. We can view the cortex and we can enter it. If the ovaries are adherent, like in endometriosis, then laparoscopy is the best option. We can't do it transvaginally. This is the transvaginal installation, where you enlarge it and go up to 2 ml in both the ovaries, but drop by drop, 0.3 ml, count 30 seconds. Again, 0.3 ml, count 30 seconds. Otherwise, it will spill out. And we have to see that it gets properly absorbed into the cortex. Laparoscopically, it is under direct vision. You see how small streak these ovaries are. So once you hold in it, you can inject it very slowly. And now we also prefer lifting the ovary beneath the abdominal peritoneum, and then trans-abdominally, we can use a spinal needle and drop by drop inject it in both the ovaries. So this is a publication in an international journal of fertility and reproduction, where we have published our promising future of PRP treatment for ovarian rejuvenation and in-house experience of an IVF institute. We represented 45 patients. 18 had a negative outcome and 8 opted for donor egg. 10 are still following us up. 27 patients had positive outcome, out of which 8 conceived naturally, 1 IUI and 18 IVF. And there were 7 live births in natural, 1 ectopic, 1 single in IUI, and IVF pregnancy with single embryo transfer, 5 patients, 5 live births, double embryo transfer, there were 2 twins, 6 miscarriages, and 5 singleton live birth. So it concluded that ovarian rejuvenation by autologous intraovarian infusion of PRP can be conceived as a newer potential treatment for diminished ovarian reserve as well as premature ovarian insufficiency. Another interesting study which we have submitted for publication but not published as yet and not accepted, it's under review right now. Total 52 patients with recurrent pregnancy loss who had no other reason but there was a low AMH. Recurrent pregnancy loss is normally 2. But here we considered 1 because time is very important for these patients when their AMH is less. And we found that out of these 52, 26 conceived through IVF after the ovarian rejuvenation, 8 conceived naturally, and then 18 have left to follow. 20 have already delivered and 6 were miscarriages, and out of naturally 7 delivered and 1 miscarriage. So this has also gone to the Journal of Immunotherapy where it is under review. Total up to December 22, I have not counted the 2023 patients, but December 22, we had 115 patients where we have done bone marrow derived stem cell therapy for ovarian rejuvenation, where we have this data, almost 38 have a positive outcome. Now, age-wise, if we separate, there were 54 patients with less than 35. So it could be premature ovarian insufficiency, 35 to 39, 33 patients, and more than 40 years, 28 patients. So when I started that this particular patient with 0.3 AMH, and this was my first case, because believe me, to counsel somebody, and it was as early as I think 2015 or 16, I don't remember exactly. This patient, they both are homeopathic doctors. And when I counsel them that this could be a possibility, you have got a miscarriage, you are still very young, we don't need to go for donor eggs, and we can do ovarian rejuvenation and then to try to conceive naturally or IUI. And they did it, they conceived naturally. And while she's holding this girl, she is already pregnant for the second baby, and she has delivered a second daughter also. This patient from UK, when they read about ovarian rejuvenation we are offering, they themselves approached me and said, we want to do this. We don't want to go for donor eggs. They came here. We decided laparoscopy, hysteroscopy, but they wanted only PRP, not stem cells. We did it, and she also delivered. What happened was, when we did the ovarian rejuvenation in August, she went back to London, and after 2 months, normally we try to do the procedures. Till then, we allow them to try naturally, because the ovarian primordial to pre-antral follicles is a 70 to 90 days cycle. So she decided to come in March to me. Her expected date was somewhere around 4th or 5th March. She arrived on 1st March. We waited. She didn't get her periods, and she was naturally pregnant before she had come from the UK. So this patient from UK in the radiology department who had amenorrhea, she started menstruating in May, July, and now again she has gone into amenorrhea, and we are planning a second bone marrow stem cell therapy for her, or ultimately donor egg. This patient was 0.04, conceived after PRP done in 2019. She conceived and she delivered a baby boy. Her AMH in 2020 went to 0.09, and she has already delivered. And the gynecologist obstetrician to whom she went called me and said, doctor, she has conceived, and she came to meet me, and she delivered there a healthy baby boy. This patient from Canada, under no circumstances wanted a donor egg. We tried 2 IVF when she came to us. Both were negative. Then we said that you are insistent in using your eggs. Why won't we do a laparohysteroscopy with bone marrow derived stem cells? In January, we did. Then after 2 months, we did a duostim. We collected a good blastocyst. She conceived in when the frozen embryo was done, and she has already delivered a baby boy. Now we talk about ovarian tissue activation. It is not stem cell or PRP, but it is a mechanical stimulation of the ovarian follicles, which we can do it because premenstrual follicles, by disrupting the hyposignaling, can be recruited. So what we do is we also inject the bone marrow derived stem cells and the ovary, which has got a good volume. There we take out the cortex, and once this cortex is removed, we try to avoid the medulla totally. It is only the cortical tissue. This is the Kawamura technique and Zhang technique, where we just send this into the lab, and in the lab this is cut into very, very minute pieces. There is a special knife and special technique. Almost 45 minutes is take. Till then the patient is in the OT, and if we have to do other tubal testing or fibroid removal, we finish that. And then with an infant feeding tube in the mesosalpinx, we put this, or we can put it auto transplantation also in the same ovary. Nowadays, we prefer the same ovary only, so the patient's chances of natural conception increases. This is how it is sutured once it is done. Dr. Niket, and my embryologist, has been trained in Denmark with Claus Anderson and even with Dr. Kawamura in Japan. So now in the OT, I'm not showing detailing of this, how they do it, but it is cut into small, small pieces. And finally, it is filled in a vial and then transported to the OT. This is the lab where it is processed. And this disruption of hyposignaling. So we have reported the first case of India where the female with 0.22, we did this procedure, and we also injected bone marrow in the other ovary, but she conceived with the ovary where the OTA was done. And she got a pregnancy first time with IVF, that was negative. Second time conceived naturally, but the corpus luteum was on the right side. She was with us, and she delivered a healthy baby in May 22, and it is reported in the Journal of Human Reproduction, drug-free in vitro activation for primary ovarian insufficiency. Now I come to the part of thin endometrium. We know adequate thickness is essential for implantation, and with It can be that the reasons for fibroid removal, surgical trauma, damaged endometrial lining due to chronic endometritis and reduced blood flow. There is plethora of treatment available, but regenerative medicine is considered now to be very helpful because we know hysteroscopy is the gold standard. You do hysteroscopic adhesiolysis, again the walls can get adhered to one another. So how do we prevent? We know in bad Asherman, 62% of patients may have 3-4 hysteroscopies, but ultimately again the adhesions come back. There, the role of regenerative medicine with PRP and bone marrow derived stem cells. You can instill it intrauterine 2 to 8 days before IUI or IVF. You can do it once or twice also before embryo implantation. Then there is hysteroscopic, where we take the patient for adhesiolysis. You can see bad adhesions, but once the adhesions are removed with an egg retrieval needle only, we inject about 0.4 ml subendometrially in all the 4 walls, and then we wait for a month and we do the embryo transfer. Intrauterine in the same cycle. So how this procedure helps? The stem cell targets the endometrial niche, and these endometrial niches are very important for the functionalist layer to develop, and they are located at the endometrium of the spiral arterioles in the basal layer. There, we don't need to use only CD133, but all CD markers can be used, and this will help in transdifferentiation into endometrial cells and activation of endogenous endometrial cells, because thin endometrium patients' basal layer is also damaged. You can feel a few patches of endometrium surrounding the spiral arterioles, and we need to target that. With intrauterine and hysteroscopic, it is a blind procedure, but there is another procedure where we can directly reach there. Once they start, they can differentiate into stromal, endothelial, and progenitor cells, and there will be immunomodulation, angiogenesis, antifibrosis, anti-apoptosis, improving the regeneration, receptivity, and implantation, and restoring fertility. We got the ethics committee approval, and we have the certificate from the health research and good laboratory practice, and now the last certificate which Dr. Ravi mentioned. This is our setup in the OT, where we take the stem cells, processed, and finally in the cath lab, they are being installed in our same hospital. Pre-IVF workup is you give antibiotic, you give about 2 liters per minute for oxygen for 30 to 40 minutes, vitamin C, glutathione. And in the lab, when the bone marrow is transferred, the stem cells are being separated. And then you can culture it with the PRP and prepare it for instillation. The Sepex machine will separate it. You can also do the viral testing. And after that is done, we leave a little bit of it to find the cell biomarkers, that what was it, how much of CD34, 73, 90. This is the cath lab where we take the patient, and this is the cardiologist. What we do is, from the femoral artery, we go to the opposite hypogastric or internal iliac artery. Then we negotiate through the uterine artery. And once we reach the uterine artery, we introduce the special microangiocatheters, which will go right up to the spiral arterioles, and we instill about 1.5 to 2 ml. Mostly it's 1 to 1.5 ml on both the sides. So once we take a patient comes, we take the blood for PRP. We give all the oxygen, etc. for 1 hour. Then the patient is taken in OT. Under anesthesia, we take the bone marrow. And at the same time, we do a hysteroscopy, instill the PRP, and the remaining PRP is used for bone marrow culturing. 1.5 hours when the bone marrow are separated and ready, the patient is taken in the cath lab, and under local anesthesia, the femoral artery is catheterized, and we go. And one of the gynecologists from our team remained present. We know Dr. Ravi and Dr. Natesh were there when we did our first 3 cases in January 2019. You can see here how beautifully it is catheterized, and how then there is a fluorescent dye also passed to confirm the entry. So this is the process, and this is how it will look when it goes. So they are go to the uterine artery, the stem cells are injected. After that, the fluorescent dye is put, and you can see the fluorescent dye. Once it gets inside, you can see the spiral arterioles. See, now you can see that beautifully it goes into the spiral arterioles and then comes out, and immediately surrounding the spiral arterioles are the stem cell niches where it goes, which because the stem cell niche, which is an injured tissue, will attract the stem cells. And therefore, once the stem cells get attracted and home in the damaged endometrial tissue, the endometrial regrowth starts. So this patient with 3 failed IVF, lining thin, we did this procedure. Her lining improved. We prepared her for embryo transfer in May and 2019, and 7 mm lining was formed, and she delivered a healthy baby. You can see the lining post this procedure of a woman who was amenorrheic, hardly brownish menstrual discharge. That time we did 3 cases. She delivered single, another case delivered twins, and the third case got pregnant, but she had a miscarriage at 5.5 months. And again, she has come for the frozen embryo transfer. We are awaiting the result. After that, we have done number of cases. So in the clinical and experimental reproductive medicine, we reported this first case report where we totally explained this case. And after that, there was a lady from Bangalore who approached us. Her frozen embryos were lying in Bangalore. She had a myomectomy. She had a DNA done due to miscarriage, and her endometrium was not improving with natural cycle, stimulated cycle, or hormone replacement. When we explained to her this procedure, she agreed. We did this procedure. She came to me that my menstruation has improved. Now I'm having pure red blood flow and even clots are passing by. She went back to Bangalore to her clinic. She got the embryos transferred and she delivered 2 healthy babies. You can see this patient who had severe fibrosis, adhesions. Again, tuberculosis is a really bad disease for the uterine lining. She had a miscarried DNA, 2 IVF failed, 1, and again she was advised surrogacy. She came to us, we did this procedure, and she delivered healthy twins in February 2022. Then we decided to publish a pilot study of 12 cases for thin endometrium with this procedure. And we published it in the Journal of Regenerative Medicine. And the outcome was really wonderful because out of 12, 1 did not have a result because she was not going to respond. We didn't want to do it, but she insisted. Out of the other 1 went for surrogacy, and 2 have not still taken the treatment, but we had 5 deliveries after this. So this was a paper which was very heavily impactful, that even though gestational surrogacy is the last option, before that, for Asherman syndrome and endometrial atrophy, this procedure should be considered. Total today, till 23, we have done 38 cases, 12 patients positive and delivered some of them, 2 patients negative, 16 still trying, 3 have lost to follow-up, 4 patients conceived but miscarried, and 1 patient opted for adoption. Now the scaffold system also we are planning to learn that if we can do it from the fibrin plug, but there are hydrogels available, nanoparticle delivery where there will be a sustained release. And interestingly, now we have extrapolated this treatment to PCOS patient and endometriosis patient also. The theory being that in PCOS, the Th1 response is very high. And human mesenchymal cells can suppress Th1. Th1 is one which is causing the internal inflammatory environment and giving the PCOS bad quality eggs, embryos, and not even supporting a pregnancy. So the ovarian function may recover after cessation of autoimmune reaction and the regression of concurrent endocrine disease in accordance with these alterations. So human mesenchymal cells preserve the capacity to suppress Th1 response that may influence the internal inflammatory environment of PCOS. We are preparing the data. We have almost done for 10 plus cases and we have got positive outcomes, I think, in almost 40% of the patients. Endometriosis again is an inflammatory response with increased cytokines, which could affect fertility via alteration of ovum formation. So recent experiments in both animal and human models has documented promising results of stem cell therapy for the restoration of fertility in patients with endometriosis. More studies are needed and our own study is going on. Role of regenerative medicine in male infertility. Dr. Ravi, Dr. Natesh would say more about it, but we are doing cases. The spermatogonial stem cell niche disturbance is there, and there are evidences that this could improve. So we have tried for oligoasthenospermia. There are experiments when one testis of the mice is giving busulfan, it is knocked out, and then both the testes are knocked out, and then you inject in one and not the other, and they have found that spermatogenesis is observed. Even there is Sherman Silber who is doing via RT testes, and we have now developed one new technique for Sertoli cell only syndrome patient, and we are waiting for the outcome. If it's good, we will be publishing it. It is a little more advanced technique with stem cells, but the injecting technology. This patient, we just instilled it into the testes, right inside and beneath the scrotal skin, trying to be near the RT testes, but it is very difficult with ultrasound also to identify. He had 2 failed cycles, and then we did this, and after that they got a blastocyst and a healthy baby was delivered. This patient, because tobacco causes very bad sperms, so had very bad sperms, all 2pn arrest. We advised this procedure. Her his DA5 was 61%, and we gave antioxidants, everything. But then when we did this bone marrow derived stem cells in this patient, we had 8 embryos, 3 fertilized, transferred, and a healthy baby. And this is the setup that we have at our hospital, where we have the full class 100, class 1000, class 10,000, quality control lab also, biometrics also, and air showers, so that only limited person can enter there, and the processing is done there. These are the classified areas, the private preservation areas, the dynamic pass boxes, the media preparation room, sterility testing laboratory, stem cell manufacturing unit, master cell bank and working cell bank, hematology part, the biosafety cabinets. So to conclude, I will say health and reproductive capacity are closely linked, and platelet-rich plasma is a boon for patients, for tissue regenerations, and especially in ovarian and endometrium. Stem cells generates intense scientific and clinical interest, so that it is a new treatments for a variety of degenerative diseases, and now it has become a game changer, offering solution for scores of women suffering from premature ovarian insufficiency, poor oocyte quality, endometrial degeneration, damage, menopausal symptoms, spermatogenesis, PCO, and endometriosis. With that, I thank Dr. Manish, Dr. Ravi, Dr. Natesh, and Dr. Chamila for having me over here, and all the listeners who have listened to me. Thank you.
Thank you so much, ma'am. Such a promising field, and I think it's going to be a game changer, as you said. And I will start with one delegate saying it looks like magic, because unexplained infertility, azoospermia, and endometriosis, PCOS, every condition, when you say that it can be corrected to a point, it seems very, very promising for the future. Let me start with the main question, ma'am. What are the indications of PRP, and when will you go for bone stem cells? What is that particular indication?
So my preference would be that younger patients, PRP is good enough. But if the AMH is very low and we are doing a laparoscopic surgery for any other reason, I would still prefer bone marrow derived stem cells. Of late, I'll counsel more for bone marrow derived stem cells. But if the patient is young, doesn't want to use bone marrow, then at least PRP. Older age group, 35 plus, definitely bone marrow derived stem cells. That is what I would prefer. PRP is the second choice. Younger patients, the platelet-rich platelets could be more robust, and then it could give a better equally good or slightly inferior. But older patients, I'll definitely go for bone marrow-derived stem cells.
And you talked about endometriosis where you can use it. Patient has got chocolate cyst, multiple adhesions and all that. Like, is it, will there be a point in doing a bone stem cell rejuvenation for such ovaries? Will it work?
Yes, we have recently started that. When we remove the chocolate cyst, people have started using sclerotherapy, but I still don't use sclerotherapy. But after removing the chocolate cyst, if there is no oozing, the patient is fine, we inject it in that ovary also and the opposite ovary also. Because endometriosis is now becoming one indication for regenerative, because they do have cells, they do have oocytes, oogonia, but to make them regenerate, because they are already damaged because of the chocolate cyst, this option is good.
Okay.
And in fact, I had a doctor from Australia with whom I was discussing. They are not doing this much of therapy, but they are of the opinion that this should work in patients with endometriosis also.
Because the maximum damage happens in endometriotic patients to the ovary. So it should be a viable therapy for such patients. There's one question where they have asked, is there any medical management to optimize the outcome of regenerative therapies?
Medical management, look, after doing the platelet-rich plasma, or we do the bone marrow stem cells for ovary, when it is a POI or diminished ovarian reserve, we would want to be the patient to be on DHEA, patient to be on coenzymes, vitamin C, all the supplements, exercise, yoga, acupuncture, whatever they want to do. Exercise, aerobics are good. Testicular, we also would want to give the coenzymes, carnitine, arginine, whatever supplements we can give for 2 months, because we know that whatever we have instilled today, the outcome will be seen only after 2 to 2.5 months, as spermatogenesis and oogenesis is a process of 60 to 70 days. In thin endometrium, we will put the patients on hormone replacement therapy, and we will continue that. And hormone replacement with last 5 days of progesterone, see the blood flow, because we don't want the adhesions again. Sometimes if it's a very bad adhesiolysis, we also will put a Foley's catheter inside for a week. And for PCO, we don't give DHEA. We just give the coenzymes and the anti-insulin agents like metformin, decarbonyl, inositol, etc.
Okay. So for each condition, it will be an individualized medical therapy so that it will benefit, it will add on to the results. And what is the case you will avoid for a regenerative therapy, ma'am? The contraindication for regenerative therapy?
Look, I tell you, today itself, we had a patient who had non-Hodgkin's lymphoma, 22 radiotherapy taken on spine D4, 5, 6, and in 2008, and had the chemotherapy also taken, R-CHOP therapy. Then she had 2 cycles, failed in another city, Pune, 2 eggs, no embryos, 4 eggs, no embryos. She came to us, we did PRP only because she is already on a wheelchair. So we didn't want to do the bone marrow. She's 38. But I said, you take a chance. Otherwise, donor egg option is there, which she didn't want. We did that. We did her IVF, 5 eggs, 3 grade A embryos on day 3. We transferred all 3 and she is positive. So all the indications we can take, but where I will not do on ovarian rejuvenation is a very bad autoimmune SLE, which is not going to allow the ovary because antibodies will keep on damaging it, or patients with any existing malignancy at present right now, or severe hemopoietic disorder. That's because we don't know the bleeding, etc., what can happen. So these are the patients, and an abnormal karyotype. Definitely there we are, male or female, we are going to avoid, because though they are saying now that the stem cell therapy can be extrapolating as a gene therapy, we cannot do it. As of now, this should be the exclusion criteria.
In your study, the exclusion criteria was a platelet which was less than 70,000 and a coagulation. And this question you have already answered, madam. I'll just ask you to recap again. It will be mode of administrative procedures, which is better. They are talking about scratching, intrauterine injection, or just infusion.
For me, if you think the same cycle and the lining is not very thin, but you want to improve the receptivity. Patient has not got a good result after 1 or 2 good embryo transfers also, intrauterine would suffice. The lining is 8+, everything is fine, but the blood flow you are not happy, then you can go ahead and do just simple intrauterine. Once or twice. If the lining was 6, it's not reaching higher, also you can do 2 times. I do it 2 times at 3 days interval, if required, very rarely. If the patient has some surgery done, DNE, and there are some adhesions which you can see on scan, if you are doing hysteroscopy, might as well, because you are doing hysteroscopy, subendometrial investigation would be a better outcome. And when everything fails, 4 5 hysteroscopies also fail, the menstruation has stopped, and lining is 2 mm, 3 mm, the repeated, there is intrauterine fluid coming up, then the uterine artery spiral arterioles is what I will prefer.
And when will you put the PRP, ma'am? What is a day of transfer, PRP?
2 to 8 days before,
2 to 8
ideally.
days.
Not before that. Before 8 days, intrauterine will not have effect. If
Effect.
you're expecting thing, you can put once on day 5, once on day 10 or day 12, and then the embryo transfer.
Okay. And when to expect the results, or how to assess the improvement?
Look, in the intrauterine part, when you are doing the transfer or IUI, you can see the lining has gone up and even the blood flow changes. You can see the blood rushing to the endometrial cavity. So that is one thing. In the hysteroscopic subendometrial PRP, the effect can be long lasting. We don't say that immediately in the next cycle you have to do it. You can do it after 1 or 2 or 3 months also. And as such, we have not evaluated for how many months that effect will remain. If the patient does not conceive, we have to analyze other factors. And if the lining is good, now you don't need to repeat the hysteroscopic subendometrial PRP. And bone marrow, intrauterine spiral arterioles, we have done only once for all the patients. We have never repeated that.
Okay.
And the results can be seen in 2 months to 3 months. And right now, what we are doing for this patient who had a miscarriage, her lining is still good.
Okay. So, what is the dosage guidance for regenerative therapies? How can we personalize for each patient based on the grade of disease?
Look, you have to count the cells. In platelet-rich plasma, it becomes 3 or 4 times more. If you have started with 2.5 lakhs, it could go to 8 lakhs, 10 lakhs. That is one sign. Second, you have to see that once you take the drop, you know how much. Then you dilute it. So we know that this much amount of platelet is going inside. That will be about 2 ml in both ovaries or 0.6 ml for intrauterine. More than that, it is just going to come out. Even when intrauterine you put a drop, wait, count 30s, again put a drop. Otherwise, you put it inside and it will gush out. Very slowly you have to do it. And subendometrial hysteroscopic, it will be almost 0.7 ml in all the 4 walls. So 2.8 ml will be the volume. And intrauterine spiral arterioles is about 1 to 1.5 ml in both the femoral arteries. When we cannulate, go to the spiral arterioles.
Thank you so much, ma'am. Yeah, it's all new to us, but it looks so promising. And then any ultrasound findings to prognosticate the outcome of regenerative therapies?
Yes, that is a very good question. For the endometrium, you can use the lining, the thickness, the blood flow, and also the uterine artery RIPI. All these 4 will prognosticate that yes, it's worked, because you will not see the free fluid coming up. For the ovaries, there are 2 parameters. One is the day 2 FSH. FSH will respond faster than increasing because AMH variations are very low. On an average, if it was FSH, say 20, it will start coming down. AMH may remain same. Most of the time it has increased and very rarely it has decreased. But FSH definitely goes down. And the ovarian AFC will not drastically improve. Like patient has 2 and 3, 5. It will not go to 10, 20. But yes, you can find 1 or 2 odd follicle coming up. But the quality of the follicle will be much better.
And any hormonal changes post-regenerative therapies have been identified, and how to change the dosages of the injections, suppose there's a change in the hormone levels.
the change will not be that drastic. So these patients will ultimately remain poor responders, okay, or hyporesponders. So these patients here, you have to decide that young patient, you can still go with just FSH because their endogenous LH will be good. Older patients, definitely FSH plus LH, both you should add. But there is no need to give 450 and 600. Maximum is 300, very high BMI 375. And young patients, even they will respond equally well with low weight to 225 also.
And some patients have got a persistent endometrial fluid collections when you're going for a transverse. For these patients, regenerative therapy will help.
Very helpful. There is a paper, I think I read in the ASRM, that they do 3 to 4 times in the follicular phase before transferring the embryo. And continuous, this would be good. But we prefer a high antibiotic. Then we also aspirate sometimes. But if there is minimal fluid, we don't touch it and we go ahead and put the embryo.
And PRP or bone stem cells, if you're going for a regenerative therapy, which will be the choice?
For me now, bone marrow.
Bone marrow.
It is the choice now.
How to optimize IUI with regenerative therapies?
Yeah, so if your patient, you have given the HCG trigger and on the day of the trigger, you find that the lining is not optimum, then you should definitely next time in the cycle plan out that you do the regenerative medicine, like you do the intrauterine PRP before you give the trigger so that you know that the lining has reached the required level.
I mean, you've already mentioned that, ma'am, but somebody wants to know again, please suggest the ovarian rejuvenation protocol and which instrument is used.
The ovarian rejuvenation protocol is PRP, you do it, and then the pellet that is formed will be dissolved in 2 ml. So 2 ml, 4 ml will be the volume. We use the same egg retrieval needle, aspiration needle, oocyte aspiration needle. We attach the biopsy guide, we go, but till the tip, we don't allow the air. So when the insulin syringe, we fill up the PRP. And then we just see that it has reached to the edge and the drop comes out. Then we go inside and we put into the cortex 1 vaginal puncture only, and we try to rotate the needle. Don't puncture the follicle because it is not going to be useful there. Sometimes the ovary is very small. Then in such patients, you can stimulate the patient with letrozole maybe, and when a follicle develops, you can easily identify the ovary if it is a TVS procedure. You can aspirate first that follicle if you want, or you go inject everything, and before the last drop, if you are still wanting to inject, you can aspirate. Otherwise, no need to aspirate. That is just to identify the ovaries. And 2 ml very slowly is injected in both the ovaries, the right and the left, with the same oocyte aspiration needle. Laparoscopy also, we use the same needle.
Thank you so much, ma'am. And can we adopt, like, suppose you see a patient with thin endometrium or a premature ovarian, the reserve is very low, and you're not gone for IVF, can you straight away go for rejuvenation therapies, or you will do a cycle of IVF and then if she fails, you will go for a rejuvenation therapy?
That yes, we can counsel the patient that we do a cycle of IVF. If there is a bad response, we go for rejuvenation. Immediately, we will not say that we will do it. But if the patient already has one failed IUI, IVF or a miscarriage, then I would suggest that yes, we go with this first.
Ma'am, what's the cost of the procedure?
The PRP for the ovarian rejuvenation, it is almost 45 to 50,000. Laparoscopically, it will be the added cost of laparoscopy, which could be another 45 to 50. And bone marrow stem cells for both the procedures for ovary TVS could be about 60 to 80, and laparoscopy could be about 1 lakh plus medicine anesthesia. And the uterine artery spiral arterioles, the cost is almost 1.75 to 2, including the ICU stay, because once the procedure is done, you have to put sandbags on the femoral artery and observe the patient in ICU for 6 hours, then shift to the room and the next day travel. So patient who come from out of Anand, they need to be 1 night or maximum 2 nights only in the hospital, and then they can go and resume normal work.
Not so expensive for such therapies, which like where they do not work with other methods. When you're going for I think it's not so expensive for that. And is there any role of endometrial biopsy pre and post regenerative therapy for the endometrium?
Not really, only you want to document, but we don't want to injure it. So scratch and little pivel is fine. But what is it going to say unless you are looking for endometritis or plasma cells?
And any problem of oncogenic potential of these stem cells, ma'am? Because
Not really, because these stem cells are multipotent. They are not totipotent, like we take from the embryos, the embryonic inner cell mass. These are really bad because they can also convert into the extraplacental tissues. So that is not correct. Here, the tumorogenic property is very, very less, very, very, and it is documented from papers all over the world, hardly any.
Any chance of prion diseases because you are changing the milieu of the ovary and the testis? Any chance of that? The Jacobs-Creutz's disease and all that. Any chance of those diseases, rare diseases happening?
No.
No, not okay. Like there's that question you answered, madam, but somebody has asked again. What will be the frequency of injection of PRP or stem cells for thin endometrium and for poor ovarian reserve? How, like, suppose she's not improving, like, will you repeat it again?
Yes, thin endometrium intrauterine, you can repeat any number of times. Hysteroscopic subendometrial PRP maybe once. Or if the patient still after 5-6 months wants to do it second time. But if that also doesn't work, because if the first time PRP has not worked, hysteroscopic second time will definitely go with stem cells only.
Ovarian, madam?
Ovarian, we do PRP. If not work, then we go for stem cells. Like that lady from Canada, first we did TVS PRP, it didn't work. Then leprohistro bone marrow we did, and then we did a IVF cycle.
What are the regulatory mechanisms we have to keep in place before we do? Suppose somebody prepares and gives us PRP and we do it in our center, like should we inform a particular authority?
I mean, PRP, I don't think there is a need to inform. But for stem cells, definitely, because it's an experimental procedure and you have to have the proper certifications for that.
So we have to apply to the directorate here.
Yes,
and
now the guideline says that if you are using autologous, not allogenic, and you are doing it without any chemical treatment or without any passages, it does not matter. But if you are doing that, then definitely you have to take the permissions.
Because even for ovum pickup and embryo transfer, you're supposed to sign Form F here. So I don't know what else.
Protocol that all signing, it is an experimental procedure. Previously, we used to take audio-visual consent. Now only audio consent is required, not visual.
Thank you so much, ma'am. We know, like any new therapy which comes, everybody has many inhibitions about it. But once it is established, then everybody claims that they've done. But going into a new field and flourishing in that, it is an extremely, very, very rare feat, madam. Thank you so much for showcasing all your efforts. And it will be a very great learning experience for every specialist who has joined here. All of them have given me phone calls and I've given the number to them and they've joined here. And it will be very, very useful for the future. Thank you. Thank you so much for such an enlightening talk. Madam, I would like to thank Dr. Natesh for the opportunity. And I had a pleasure moderating the session. Thank you so much, ma'am.
Thank you, madam. Thanks for the time. And it's been an hour. So, wonderful sessions because very informative. And we are getting a lot of comments here. So, I think we would like to end the session, madam. And one end note from Dr. Ravi, sir.
Actually, there's one more question, ma'am. Can I ask that? One person has asked. Dr. Priyash has asked, a case of thin endometrium with 6.8 mm, even after intrauterine PRP, as well as a myometrial cyst 1 centimeter size. What can be done now?
So myometrial cyst, if hysteroscopically you can open it and drain it, it is best. If 6.8, I would not say is bad. Up to 6.5 to 8 is a good lining. The blood flow, the texture is more important. But if this has not happened, then do a hysteroscopy, very proper removal of the cyst if you can drain it, and then subendometrial PRP should be installed. Yes.
Thank you, ma'am. Thank you so much.
Madam, I just want to add one thing before Ravi sir says. And sir, like, I want you to also add in this off-label use of approved stem cell therapy, so that is there any requirement for anyone to get the approval, sir?
Yeah. So there are already approved allogenic mesenchymal stem cells available in the market. Indian government is the only government in the world which has approved 6 different diseases for stem cell therapy, and these stem cells are taken from another person. It is allogenic, and it is for osteoarthritis, for CLI, and hair regeneration, and there are 6 indications. So any drug, these are all now called as drugs. When we use allogenic mesenchymal stem cells, which is available in the market, any doctor can give a prescription. For example, as an orthopedician, any orthopedician in India can give a prescription for allogenic stem cells, and the request goes through their pharmacy to Alchem company, which has this allogenic product of stem cells, 25 million stem cells in a bottle, which comes in a liquid nitrogen tank. So these are now drugs. So drugs can be used off-label. All the drugs which we used in COVID were all off-label. They were not discovered or approved for COVID, but they were discovered and approved for other diseases, but we used them for COVID. So many of our prescriptions already contain off-label drugs. So the point is what Natesh says, what is available today in India, these allogenic stem cells can be used off-label for infertility also without any extra permission. So that is the answer for your question, Dr. Natesh. And regarding Madam's talk, it was very excellent. I have been reading about all these things for more than 15 years, and I have never seen any center or any person who has handled 360 degrees of infertility, whether it is the female infertility as well as now that Madam has taken up male infertility. So she has addressed the 360 degrees of infertility. And after hearing Dr. Charmila, I also would suggest, Dr. Charmila has suggested Madam to increase the cost. So she has suggested that this is very cheap, so you can increase the cost. And
I'm not saying very cheap, but it is quite cost effective for the work done in such a field. That's what I
Madam, that's a joke, Madam. So one point which I want to summarize is every tissue in the body has got its own tissue resident stem cell population. Whether it is the bone, muscle, tendon, ovary, cartilage, every tissue has got its own tissue resident stem cells. And now we can quantify and say there is a deficiency of stem cells. So in ophthalmology, they have a term called limbal stem cell deficiency. So there is a deficiency of number of stem cells in the limbus, which they can measure and quantify. Similarly, they have come out with a term called trabecular stem cell deficiency, where they can measure the number of stem cells in the trabecular measure and quantify and say that there is some deficiency. So, Madam, when you talked about endometrial niche, then I thought, and also about ovarian niche, now we can quantify the stem cells in the endometrium as well as the ovary, and then we can say that there is a deficiency, and that if there is a deficiency, automatically the treatment becomes, we have to supplement it with stem cells. So my suggestion is, when you are doing this OAT procedure, whatever you are saying about taking the cortex of the ovary, and then, so is there a possibility of taking one bit out of that and then analyzing it, and then we will see from a normal person, and then we will take it from an affected person, and then see what are all the contents, and I think that can be a study where we can measure. Yeah. So with this, I thank Dr. Natesh. It was an excellent session. There is no chance that you could listen to such a lecture anywhere in the world. Thank you, Madam. It was really world class.
Thank you.
Thank you, Madam. So thanks, everyone. Thanks, audience, everyone. And let us meet for the next upcoming symposium on another interesting topic, which will be given by Dr. Molina Patel. We have planned this on November 7th. And she is from Akansha Institute. Madam, few words about Dr. Molina Patel from your side.
Dr. Molina is very interested in cosmetic gynecology and vaginal lasers, but she is more interested in the PRP treatment for the O spot and G spots, and for menopausal women who have vaginal atrophy, how the PRP treatment can help there also. And most importantly, now she is also starting for the early SUI, how the PRP treatment can help. So she is going to speak on all this when she is going to take the next talk in gynecology.
Thank you. Thank you.
Dr. Natesh, you're muted. To unmute yourself.
Thank you, everyone. Thank you,
Thank
Chabla madam. Thank you, Naina madam.
Thank you. Thank you.
Thank you,
Ma'am,
Ramesh.
we are eagerly waiting to hear her also talk, Molina. Thank you.
Okay.
Thank you, ma'am. Bye.
Bye.